To all of you. Once again, welcome to the teaching session of Department of Urology, Savai Man Singh Medical College, Jaipur. So today's class again is on basics of urology. We ended the last couple of classes on the future of urology, which included regenerative medicine and immunotherapy. Today, we have just completed a complete circle and starting with the basics, that is etiology and pathogenesis of one of the most common problems in urology, that is urinary stones. So I would request now Dr. Sarvesh Yadav, and today's presenter is Dr. Sarvesh Yadav, our resident, and moderator is our faculty, Dr. Singh Hada. So Sarvesh, please start your presentation. Yes, start your presentation.
Hello. Good morning, all of one present here. Today's topic of presentation is Etipathogenesis of urolithiasis. Now I request Dr. Sarvesh to come and start his presentation.
Good morning, teachers and
Sarvesh, make it full screen.
Topic is on Etipathogenesis of urolithiasis.
Make it full screen, please. Is it full screen? Okay. Yes.
Epidemiology, site. Site occurs anywhere from upper urinary tract to lower urinary tract. Gender gap narrowing now this time because of rise in detection of asymptomatic alkali through radiographic images. Incidence of symptomatic stone did not increase significantly. Gender and age. It is uncommon before 20 years of age, and most of the age between 4 to 6 decades. Most common in women, is presented with bimodal distribution. First peak is between 30 to 39 years and second peak between 60 to 69 years. Second peaks corresponding to the onset of menopause because of lack of estrogen. Estrogen influences the protective against the stone formation and enhance the renal calcium absorption and reduce the bone resorption. Geographical distribution of urolithiasis. Most common areas where a hot, arid, dry climates depend on seasonal variation in between summers, most commonly in between summers, July to September. High temperature and sunlight induce the increase in vitamin D. Peak occurring within 1 to 2 months of maximal mean temperature. Temperature dependence from the urolithiasis primarily attributed to the effect on men likely due to differential sunlight exposure, occupations, and hydration status. Major kidney stone prevalence state in India. Stone belt state like as Rajasthan, Punjab, Haryana, Gujarat, Madhya Pradesh, Maharashtra, Bihar, Jharkhand, and West Bengal. In comparison to global platform, most common kidney stone form is North America, corresponds to 13 to 15%. Occupation. Risk factor is heat exposure and dehydration. Occupations like cooks, engineering room personnel, steel workers, glass plant workers. Exposure to higher temperature is higher incidence of urine volume. Higher incidence of urine volume, low pH, higher uric acid levels, higher urine specific gravity, and hypocyturia. Higher urine saturation of uric acid because of forms to higher incidence of uric acid stone. Sedentary occupation also form the urolithiasis, which increase the reflective of more indolent diet and lifestyle. High occupational heat stress form to heat strain, rise in core body temperature, high urine specific gravity, and excessive sweating and thirst form the repetitive dehydration and acute kidney injury and forms the renal or urethral calculi, which form the kidney stone disease. Diet and metabolic association. High food intake and low protein intake decrease the risk of urolithiasis. And obesity, metabolic syndrome, and type 2 diabetes mellitus is having increased risk to form the urolithiasis. Exact pathophysiology of mechanism in type 2 diabetes mellitus is not completely elucidated, but most probably is the metabolic state of insulin resistance. Higher BMI also contribute to the nephrolithiasis. Excrete more urinary oxalate, uric acid, and sodium and phosphorus. Urinary supersaturation of uric acid increase with BMI. Association of obesity and calcium oxalate stone is primarily due to increased excretion of promoters of stone formation. And association of obesity and uric acid stone is primarily influenced by the urinary pH. Pathogenesis of urolithiasis. Simply supersaturation of urine with stone forming salts, then crystal nuclei formation, anchoring of crystal and aggregation, and lastly form the stone. State of saturation. Saturated solution. Pure aqueous solution when it reaches the point at which no further added salt crystal is dissolved. It's called saturated solution. Solubility product. Concentration product at the point of saturation, the point at which dissolved and crystalline component are in equilibrium for a specific set of conditions. Formation product. As the concentration product increases, the point at which the solution can be no longer be held in solution and crystal form is called formation product. Undersaturated. Below the solubility product, crystal will not form. Metastable. Metastable is between the solubility product and formation product. Spontaneous nucleation or precipitation does not occur despite of urine is supersaturated. It is in this area modulation of factor controlling stone formation can take place and therapeutic intervention is directed. Unstable. At concentration above formation product, crystal will form. Nucleation and crystal growth, aggregation and retention. Crystal nucleation. Homogeneous nucleation. Nuclei form in pure solution. Heterogeneous nucleation, nuclei formation by adsorptions onto existing surface of epithelial cell. Heterogeneous nucleation, nuclei formation by adsorption onto existing surface of epithelial cells, cell debris, or other crystals. Within the time frame of transit of urine through the nephron, estimated at 5 to 7 minutes, crystal cannot grow to reach a size sufficient to occlude the tubular lumen. In the presence of urinary inhibitors, calcium oxalate precipitations occurs only when supersaturation exceeds solubility by 7 to 11 times. Stone growth theories. Free particle growth theory. Recent study, free crystalline particles can be formed that are large enough to be retained during normal transit time through the kidney. Finding based on recalculation using current nephron dimensions, supersaturation and crystal growth rates. Second is fixed particle growth theory. Anchoring site to which crystal bind. Prolong the time the crystal are exposed to a supersaturated solution, crystal aggregation and growth. Crystal fixation. Oxalate induced injury to renal tubular epithelial cell mediated by reactive oxygen species adherence to calcium oxalate crystals. Role of antioxidant. Neutralize cytotoxicity and allow retention of renal cell integrity and like as an N-style cysteine. Lower level of serum antioxidant like alpha-carotene, beta-carotene, beta-cryptoxanthine will increase the risk. Lower level of serum antioxidant increase the risk like alpha-carotene, beta-carotene, beta-cryptoxanthine. Oxidative stress implicated in diabetes, metabolic syndrome, and coronary heart disease. Gender disparity, differential antioxidant production associated with testosterone and estradiol. Increased testosterone, increased oxidative stress and stones. Increased estrogen, suppress the both. Crystal bind preferentially to redifferentiating renal tubular cells mediated by lumen membrane molecules like as a hyaluronic acid, osteopontin, and exin 2 nucleolin related protein. Randall Plaques. Randall first observed area of damage associated with subepithelial plaques on renal papillae. Initiating event is vascular injury to the vasa recta near the renal papilla. Repair of damaged vessels wall atherosclerotic-like reactions form to calcification of endothelial wall leads to erosion into papillary interstitium and then into collecting ducts, serve as nidus for the stone formation. This is the endoscopic and histological view of Randall Plaques. Structures. Structure of stone. It has two components, a crystalline component and non-crystalline component. Crystalline component is mostly calcium apatite. Deposit consists of individual laminated particles with minerals and organic layers. All crystals were coated with organic materials. Osteopontine was identified on the outer surface of the crystals at the junction of overlying organic molecules. Crystal growth. High concentration of calcium oxalate induces the local inflammation that triggers the phenotypic differentiation of tubular epithelial cells into mesenchymal cells with osteogenic activity. Bone osteoid proteins, osteopontine and osteocalcin found in the plaques. The volume of papillary surface covered by plaques are shown to correlate negatively with urine volume and positively with hypercalciuria. Growth on plaques is the primary mechanism of stone growth. Calcifying nanoparticles. Calcifying nanoparticles is self-propagating particles that participate calcium apatite on their exterior membrane, have been detected in blood products, renal stone, as well as in pathological calcifications. Promote rapid precipitation of calcium phosphate from the blood underlying physiologically unfavorable conditions. In case of enteric hyperoxaluria, no plaque is formed. Apatite crystal deposit plugging into inner medullary collecting ducts lumens, along with associated epithelial cell damage with interstitial inflammation and fibrosis. In brucite stone formers, intermediate pathology, interstitial apatite plaques and apatite crystals plugging in the inner medullary and terminal collecting ducts, along with associated collecting duct injury and interstitial fibrosis. In distal renal tubular acidosis, extensive renal calcification, papillary changes minimal to papilla, plated and contained calcium phosphate plaques protruding into dilated collecting system with extensive surrounding fibrosis. Randall plaques were rarely encountered. In cystinuria conditions, plugging of terminal collecting duct of Bellini with mass of 16 crystals, apatite deposit were also identified in the inner medullary collecting ducts and in thin ascending limbs of loop of Henle. In primary hyperparathyroidism conditions similar to brucite stone formers with interstitial deposit of plaques and associated stone overgrowth traditionally seen with the idiopathic calcium oxalate stone formers. Inhibitors. Inhibitors are molecules that raise the level of supersaturated needed to initiate crystal nucleation, or reduce the rate of crystal growth or aggregation, and prevent stone formation from occurring on a routine basis. No specific inhibitors for uric acid crystallization. Inhibitors like inorganic pyrophosphate, citrate, magnesium, polyanion macromolecules like glycosamine, glycans, acid mucopolysaccharides, RNA, urine glycoprotein like nephrocalcin, time horse fluid protein, osteopontine, uropontine, uroprothrombin fibrogen, uroprothrombin fragment 1, bicunin of inter-alpha trypsin. Citrate. Citrate reduces the ability of ionic calcium to interact with oxalate or phosphate. It inhibits the spontaneous precipitation of calcium oxalate, prevents the crystal aggregation, which prevents the heterogeneous nucleation of calcium oxalate by monosodium ute. Magnesium. It forms the complex anion with oxalate, which reduces the ionic oxalate concentration and calcium oxalate supersaturation. Reduce the contact time between calcium and oxalate molecule in vitro. Pyrophosphate, citrate, and magnesium inhibit the crystal growth. High concentration of magnesium and pyrophosphate inhibit the aggregation of nucleation. Polyanion macromolecules. Polyanion macromolecules bond with surface calcium ion and inhibit the crystal nucleation and growth. Most prominent glycosamine glycans in human urine is clonidine sulfate. Heparin sulfate interact most strongly with calcium oxalate monohydrate crystal. Nephrocalcin. Nephrocalcin is acidic glycoprotein containing predominantly acidic amino acid that is synthesized in the proximal renal tubule and thick ascending limb. It inhibits the growth, nucleation, and aggregation. It's formed in 4 isomers. Non-stone formers exceed greater quantities of 2 isoforms with most inhibitory activities. Isoform with inhibitory activities were found to contain carboxyglutamic acid residue that were lacking in the isoformal stone formers. Horsepower protein expressed by the renal epithelial cell in the thick ascending limb and the distal caniculated tubule as a membrane anchored protein released into urine after cleavage of the anchoring site by phospholipase or proteases. It is a potent inhibitor of calcium oxalate monohydrate crystal aggregation, but not the growth. It is a functional variase depend on urine pH. In alkaline urine, it is act like the inhibitors, but in acidic urine polymerize into the configuration that promotes the crystal aggregation. Osteopontin or uropontin. Osteopontin or uropontin are acidic phosphorylated glycoprotein expressed in bone matrix and renal epithelial cells of the ascending limb of lobe of Henle and distal tubule. It inhibits the nucleation, growth, and aggregation of calcium oxalate crystals, as well as to reduce the binding of crystal to renal epithelial cell in vitro. May work in conjunction with constitutively expressed Tam-Horsfall protein. Urinary prothrombin fragment 1. It is a crystal matrix protein named for its resemblance to the F1 degradation product of prothrombin. It inhibits the crystal aggregation and deposition. Bicunin. Bicunin is an inhibitor comprises of light chain of inter-alpha trypsin, alpha glycoprotein, a glycoprotein synthesized in the liver. Inhibitors of calcium oxalate crystallization, aggregation, and growth. Matrix of stone. The non-crystalline component of renal calculi accounts for the 2.5% of weight of the stone. In some matrix, the majority usually in some cases, matrix comprises the majority, usually in the association with chronic UTI cases. Heterogeneous mixtures comprises of protein, non-amino sugars, glucosamines, bounded water, and organic acid. Most commonly found proteins approximately 65%. Protein like Tam-Horsfall protein, neprocalcin, renal lithostatin, albumin, glycosamine glycans, mucoprotein matrix substance A. Substance A is immunologically unique and present in the matrix component of all stone. Inflammatory protein like immunoglobulin, defensin 3, clusterin, complement system 3, C3A, kinogen, and fibrinogen comprises the predominant protein in calcium oxalate and phosphate stone. Exact role of matrix yet to be elucidated. Summary. Urine must be supersaturated for the stone to form. Supersaturation alone is insufficient owing to the presence of urinary inhibitors. Nucleation in stone formation is heterogeneous. Subepithelial plaques serve as an anchor on which calcium oxalate aggregate and stone growth occurs. Non-crystalline component of stone is matrix. Thank you. Sure.
Thank you, Sarvesh. So, the points that I had asked you to include, I think you could not. So genetic. No. Besides that, you have these are the medical conditions which are usually associated with urolithiasis: hyperparathyroidism, cystinuria, distal tubular acidosis, primary hyperoxaluria, and medullary sponge kidney nephrocalcinosis. All this, but there are genetic predisposition also to urolithiasis, and this has been proved by many studies which have been done in twins in various countries. It has been proved by the higher prevalence of urolithiasis in patients who have a family history. So those who have a family history of urinary stones, they are 2.6 times more prone to develop urolithiasis than the general population. So I think it's a very interesting thing. We have come back to the basics of
various problems in urology. Today we start with etiology and pathogenesis of urinary stones. We know urinary stones is a very common problem. Almost 1/3 of our OPD is probably with urinary stones problem. And we also live in a stone belt area where the urinary stones are quite prevalent. It has been seen that almost 19% males and 9 to 10% females by the age of 70 years will have urinary stones. So you can understand the magnanimity of the problem throughout the world. It's not only in our country, it is throughout the world. In fact, North America is probably the highest stone prevalence. And stone disease definitely would have many other risk factors. They would depend upon various environmental factors, would depend upon the age, sex, gender, race, ethnicity, geographical area where you reside, and factors like dietary factors, plus the fluid intake. All these are very important risk factors and the factors which can lead to stone formation, besides the genetic predisposition. So I think we all are very much into treating these urinary stone patients, but the more important part is how to prevent the recurrence of these urinary stones. How to prevent urinary stones, which is such a major problem in our country. Not in our country, it's throughout the world. So I think we should focus our more attention on how to prevent stone disease and how to prevent especially the recurrence of stone, because we know recurrence is a very common problem. Those who have stone disease once, they tend to have stones again and again. So I would suggest you to create awareness amongst people regarding stone disease, about the dietary factors, about the causes of the problem. Plus, we need to focus our attention on metabolic evaluation of these patients. At least we can help many of these patients by doing a proper metabolic evaluation and even a stone analysis, and give them a proper counseling regarding their diet, and if we want to add some kind of a drug or medication which can help us. Did you speak about the drugs which can cause this problem, urolithiasis? So things to remember in urolithiasis, again, as I told you, there you are also, during history taking, you must take the drugs the patient is taking, right? So there are various drugs which help in urinary stone formation, like acetazolamide, like loop diuretics, like various antiviral drugs, retroviral drugs. Then you have indinavir, triamterene, all these can form stones. Vitamin C, silicates, antacids. So because antacids are being used so profusely, so commonly. So very important to remember those patients who have urinary stones should not take a lot of antacids also. So during history taking, this again is very important. And genetics, as I said, though we do not have a particular gene still identified which can be screened for patients of urolithiasis, but we do know that there are multiple genes which have been kind of researched into, like patients or like those proteins which are responsible for absorption and excretion of calcium, oxalate, uric acid, then transporter genes, then exchangers, so phosphate exchangers. There are so many genes which have been identified which probably would cause more stone disease. I think that's the basic knowledge of urolithiasis is very important for all of you to have, and so that we can help our patients in our during clinical approach. So if you have any query or any thing that you want to add, and Nimeshji, do we have anybody? I think Dr. Anil is there.
Dr.
With us.
Anil, Dr. Anil.
Dr. Anil can unmute and give his opinion. And if anybody else who has joined us today on YouTube or not on YouTube, Zoom, he can just. Dr. Anil, you can just open up your video and give your comments. In the meantime, Dr. Nachiket, would you like to add something? Okay. Any one of you?
We have a patient of hyperparathyroidism.
Okay.
Retrospective serum calcium is 13.
Yeah.
So she has a lower uric stone and renal stones. So
Yeah.
a simple thing that I think calcium.
Yeah, it's very important, right? So in every patient, I think even not patients who are having recurrent stones, I think at least these basic tests of serum calcium, uric acid, creatinine, and serum PTH is important to rule out some of these common causes which we can actually deal with. Because we had a patient of hyperparathyroidism, and when the ultrasound of the neck was done, they was found to have a parathyroid adenoma. So we can really help these patients to prevent recurrence of stones by these basic tests. And I think metabolic evaluation, though, is not being routinely done in our city, but we have many collection centers where we can send and get the metabolic evaluation done. In fact, I had invited Dr. Sanjeev Mehta also, probably he is not here abroad, probably. So he couldn't pick up. He is running a very big center which helps in the metabolic evaluation of the stone disease. And definitely there are other centers also where we can utilize them for proper evaluation of these patients. Yes, Dr. Anil, would you like to come in?
Yes, thank you, Shivam.
Yes, Dr. Anil.
And I always
if you
enjoy
can
your teaching
open your
programs.
video, it would be good.
I always enjoy your.
We cannot hear you.
Hello.
Yes. Open your audio also.
Yeah. Yes. I have
Your
unmuted.
audio, we are not able to hear you.
There is something wrong because
your voice is still not there.
Volume.
Can you increase the volume? Maybe the volume is not there.
Can you hear me?
In the meantime, anybody else? We have Rahul Singh, Brij Mohan, Dr. Brij Mohan Joshi. All of you, anybody wants to make any comment? Please go ahead. जैन साहब आ गए पर ऑडियो नहीं आ रहा है.
Hello.
हाँ जैन साहब थोड़ा जोर से बोलिए. फिर बंद हो गया ऑडियो. जोर से बोलिए.
Can you hear me?
थोड़ा सा louder. The voice is a little.
Can you hear me?
Yes. Go ahead.
I have been associated with this Euro lab of Mehta ji, and I have been doing stone analysis and 24 hours urinary analysis evaluation in almost all patients.
Great.
I have found some surprise findings. Like I found 16 stone in 2 patients where I never expected.
Pardon?
16 stones in 2 patients where I never expected.
Okay.
And the commonest is calcium oxalate, monohydrate, and dihydrate, along with calcium apatite sometimes. And in 24 hours urinary analysis, the commonest finding is low citrate levels, and sometimes in almost 30 to 40% high sodium level.
Okay.
So these 2 things, along with pH and volume correction, need to be done.
Yes.
I don't have a very analytical data, but empirically, I find that when I have been doing this and advising accordingly, those patients who are in my follow-up, very few of them had recurrence. Majority did not have recurrence. This is my data of about 7 years. So I would suggest, hello? Hello?
Yes, go ahead.
So I would suggest that all centers where there is a significant stone load should do these two tests. This will not only help individually to us, but I think a lot of data will be collected so that we can advise the patients and the our future urologist how to deal with the recurrence of a stone. This is my short, small experience.
Yes, Dr. Anil, very good suggestion. And even I was thinking in the same lines. I think USI is doing a lot of research work in various problems like prostate and prostate biopsy, and there are other conditions also. I think this is a major problem in urology, the stone disease, and most of the major institutions and centers who are doing this metabolic evaluation should come together and have a collective data on in our country about. I think that's a very good suggestion, and we should go ahead and we should suggest USI also to have a multi-centric study on urinary stones.
Yes.
Thank you, Dr. Anil, for joining us.
Thank you.
And I would request anybody else, if has any kind of a comment to make, please go ahead. Residents, do you have anything to say? If not, I would request our moderator. Yes, Dr. Anil.
No,
I think thank you for joining us and giving this very important suggestion. I think it is a high time that we do a multicentric study of doing a metabolic evaluation in urinary stones. Thank you very much. Dr. Ajay, please give your remarks and then we will wind up the session. Yes.
Thanks, Sarvesh, for valuable information about the etipathogenesis of urolithiasis. And I would like to thank our mentor and guide, Singh sir, for enlightening us deep knowledge on urolithiasis pathogenesis, especially about the genetic prevalence and the connection of the urolithiasis with the genetics. Thanks.
Thank you, Ajay. And then we will wind up our today's session. I thank all of you who have joined us today, either on Zoom or YouTube. Thank you very much and have a good day.